So welcome guys. I think you all can see my screen now. I think I'll just make it full screen. This is the uh, Pain Journal Club. Now we are in the season 2 and this is the last journal club of this season. Today we are going to discuss about chronic pelvic cancer pain, and we have some very good speakers lined up, as well as we've got some great faculties as well. So I think this is the time when we should begin. I've already shared my screen. I'm just checking whether we are live. Yes, we are live on all the networks as well. So just let me quickly introduce and then we begin. Okay. So pain medicine world over has got a lot of similar issues. There are diverse issues which are variable standards. And these variable standards are leading to lots and lots of different treating methodologies. There are different learning requirements because even the physicians who learn this unique discipline, they are not the same. There are different offerings, and as a result, money and time, they are quite a big limiting factors if somebody wants to learn and practice this unique discipline. So Mumbai Pain School is supported by Penmetcha Spine Wellness and Pain Relief Center, and our aim is to bring in the online education to various social media platforms, including Facebook, Instagram, Twitter, and we are focusing on online learning, but also on on-demand learning. We have both free and paid content. We are very fortunate to have held lots of hands-on workshops as well, and expert faculty from all over the world have supported us from time to time. It is said that the best teachers, they teach from the heart and not from the book. A journal club is nothing, it's just a club. Only difference is here we're going to critically evaluate the recent academic literature, which is based on a defined subject. Attendee participation is most welcome, and you can ask questions, comments, suggestions, all are welcome. Guys, the most difficult part is that it's tough to be regular, and as a result, we see many times lots and lots of people. They're always changing. We get to see the new people every time, and it's very tough to be regular. Even Harrison held his journal club twice a month, and his purpose was critical evaluation of the recent academic literature as well. Discipline and time is extremely important, so I request the speakers to stick to their timelines. Healthy skepticism or praise is most welcome and appreciated. This is a bit about me. I am associate professor and practicing in Mumbai, and today we have faculties with us. Dr. Taruna Waghray Penmetcha. She is MD, Division Chair, Acute Pain, and Associate Program Director in Pain Fellowship in the Department of Anesthesiology and Pain Management at the John H. Stroger Hospital of Cook County, Chicago. She is also Adjunct Associate Professor at the Rush Medical College in Chicago. She is a part of several hospital-wide committees. She's got multiple publications in peer-reviewed journals, and she's been recognized for her service rendered to the Pain Fellowship and patients. She's also won the Attending of the Year award, so very decorated faculty. Welcome, Dr. Taruna. Just let me find her and then upgrade her to the panelist. Yes, I can see her. Okay. So, welcome, Dr. Taruna.
Good morning.
Yeah. So, so we also have today with us Dr. Krishna Poddar. She's done her fellowship in pain management. She's a pain consultant in Kolkata. She's trained in the US, Europe, and Australia. She's a director of Kolkata Pain Clinic, and she's a faculty in national and international pain conferences. And she's also been awarded the Healthcare Pioneer of the East 2020 for pain management. I think we should now go on to the speakers. I'll stop my sharing and I will now request the speakers to continue. I have made you guys co-host. I think Dr. Sasmit, you're going to present first. You can just start sharing.
The video is off.
Okay, just a minute. I'll just check. Yes. Yes, I can see your screen now. Can you put up your CV slide and make it full screen?
Yes.
So I'll introduce you. Yes, so Dr. Sasmit Lotliker is MD in Anesthesiology from Bangalore Medical College and Research Institute. He is currently working as fellow in pain medicine at the DYPU University, Navi Mumbai. And he has been the ex-associate consultant critical care at Manipal Hospital in Goa. So over to you, Dr. Sasmit.
Good evening, everyone. Today I'm going to discuss this article on pulse radiofrequency of the sacral roots, improving the success rate of superior hypogastric plexus neurolysis in controlling pelvic and perineal cancer pain. This is a randomized trial which was published in the Pain Physician Journal 2020 March edition by Heta DF Mohammed AA et al. At the South Egypt Cancer Institute, Egypt. So introduction. Chronic pelvic cancer pain is a disabling condition emanating from tumor involvement of the pelvic viscera, muscles, and neural structures. Interventional denervation therapy is required in 10 to 15% of the patients with intractable cancer pain, which is resistant to conventional analgesics. Superior hypogastric plexus neurolytic block, that is the SHPN, is the mainstay management for pelvic cancer pain of visceral origin when opioids will fail. At best, the superior hypogastric plexus neurolysis has the potential to control only pain in 60 to 70% of the patient. This is because of alternate pathways for conduction of pain via the sacral pathway. Sacral roots have been a target for neuromodulation in chronic pelvic cancer pain and could be a potential target for pulse radiofrequency. So what are the aims and objectives of this study? To find out if combining the superior hypogastric neurolysis with pulse radiofrequency of sacral roots would block most of the pain emanating from pelvic structures and improve the success rate of superior hypogastric plexus neurolysis in controlling pelvic and perineal cancer pain. The methodology implied is a prospective randomized control trial. 58 patients who were suffering from chronic pelvic and perineal cancer pain were enrolled. This trial was performed and approved by Medical Ethics Committee. Written informed consent was also obtained from all the patients. The patient was then randomly assigned to two equal groups using a computer-generated software, and sealed envelopes were used which were opened before the procedure. 29 patients each were divided, of which 29 patients received the superior hypogastric neurolytic block combined with the pulse radiofrequency of sacral roots, that is S2, S3, S4, and the remaining 29 patients received superior hypogastric plexus neurolysis alone. So the included criteria were adult patients with chronic pelvic and perineal cancer pain, post-surgical pain after surgery for pelvic cancer, visual analog pain scores of more than 5. Despite the treatment with standard analgesic regimen like oral opioids, acetaminophen, and amitriptyline. Exclusion criteria were coagulopathy, patients having infection at the site of injection, severe cardiac compromise, intolerant to sympathetic block, and patients who could not tolerate prone position for a long time. Statistical analysis. The analysis was performed using SPSS software version 22. Normality of the continuous data distribution was tested with Anderson-Darling test. Categorical data comparisons were made using the chi-square and Fisher's exact test. Continuous data and point-by-point comparisons were done by unpaired student t-test, whereas comparison for global perceived effect and morphine consumption were made using the Mann-Whitney's test. A statistical significant difference was considered when the p-value was less than 0.05. This is a flow chart showing how the patients were divided. And finally, we had 26 patients remaining for the analysis per group. Coming to the superior hypogastric plexus neurolysis procedure, patient was first placed in prone position on the radiolucent table with a pillow under the pelvis. An intravascular line was established and 1 liter of normal saline was administered. All the basic monitors were connected to the patient and 5 mg of midazolam was given for sedation. The AP fluoroscopic image was obtained with cephalic orientation to align the lower border of L5. C-arm was then oriented to 20 to 25 degrees oblique. Point of entry was marked at the level of L5S1 disc. 3 ml of 1% lidocaine was infiltrated. 15 centimeter 20 gauge curved tip needle was inserted in the direction of the beam. Needle was advanced under oblique view, hugging the lateral margin of L5 vertebrae or L5S1 disc until a reasonable depth was obtained, that is around 7 to 8 centimeters. 1 to 2 ml of contrast medium was then injected after negative aspiration to outline the L5S1 junction both up and down without posterior spread towards the nerve root. That is a C-shaped concavity facing posteriorly, as we can see in the figure. The AP view was then obtained to ensure favorable dye position. A paramedian globular lesion was seen at L5S1 position. 6 ml of mixture of lidocaine 2% and alcohol 100% in a 1:1 ratio was injected. The procedure was then repeated on the other side. So this figure shows the globular image which is seen after the injection of the dye. Next, coming to the radiofrequency of sacral roots procedure. The AP image with cephalic orientation and slight obliquity was obtained to visualize the sacral foramina. Needle entry point was in the upper outer margin of the selected foramen. A 10 centimeter curved tip radiofrequency cannula with a 1 centimeter active tip needle was introduced. Lateral view was then obtained to visualize the needle residing just anterior to the sacrum. At this point, threshold of sensory stimulation below 0.6 volt was seen in all cases. For the S2 root, pain was noted in the lower limbs and pelvis. For the S3 root, pain was noted deep in the pelvis and external genital organs. Whereas for the S4 root, pain was noted in the perineal region. So this is the AP posterior anterior X-ray image of lumbosacral region showing the sacral foramina and the radiofrequency needles which are present inside them. After the 3 needles were placed in a position at a desired target, 5 cycles of pulse radiofrequency, 2 minutes each, were delivered of 20 milliseconds, 500 kilohertz radiofrequency pulses at a rate of 2 hertz. The maximum temperature voltage was automatically controlled to 42 degrees. The needles were then removed and the same procedure was repeated on the other side. Here in this image, we can see a lateral view of the lumbosacral region, which shows the 3 needles at S2, S3 and S4 sacral foramina. Results and discussion. So as we see in the first table, the demographic data of the patient and the patient characteristics were not very significantly different in both the groups. However, the vast pain scores of post-procedure of more than 50% reduction was seen at 1 month and 2 month post-procedure, whereas no significant reduction was seen at other duration. This is a table which compares the mean difference of VAS between the superior hypogastric plexus neurolysis and the pulse radiofrequency group with the superior hypogastric plexus group alone at different intervals, including 2 weeks, 1 month, 2 months, 3 months, 4 months, 5 months, and 6 months. So as we can see here, significant reduction in the mean VAS score was seen at 1, 2, and 3 months, but no significant reduction was seen at 4, 5, and 6 months. This last table shows the comparison between the two groups on the morphine requirement. Morphine requirement was basically assessed by seeing the requirement of morphine sustained release tablet in each of the groups. So when we compared, we saw that significant reduction in morphine requirement was seen at 2 months and 3 months as compared to, whereas no significant reduction was seen in any of the other duration. Also, the level of satisfaction with the procedure as seen by the global perceived effect was much greater in the SHPN group, that is the superior hypogastric plexus neurolysis plus pulse radiofrequency of sacral root group as compared to the superior hypogastric plexus neurolytic group alone. The analgesic effect of the pulse radiofrequency is basically thought to be due to the following mechanisms. Electromagnetic wave induced neuroplastic changes rather than thermal destruction. Potentiation of the noradrenergic and serotonergic descending path, pain inhibitory pathways and inhibition of excitatory nociceptive C fibers. Pro-inflammatory cytokines such as tumor necrosis factor alpha and interleukin-6 were reduced in neural tissues exposed to the pulse radiofrequency. Upregulation of C-FOS expression in laminae 1 and 2 of the dorsal horn, and suppression of activation of microglia cells and the P38 signaling pathways which occur after nerve injury. To conclude, for patients with cancer-related chronic pain, pelvic and perineal pain, a combined approach using the superior hypogastric neurolysis followed by pulse radiofrequency of the sacral roots S2, S3, S4 provided a significantly better analgesic effect as compared to the superior hypogastric plexus neurolytic alone. The limitations accepted were a certain opioid protocol could not be fixed for all the cases, and instead they used the opioid conversion to sustained release morphine tablet. Coming to the critical analysis, a caudal catheter with an active tip capable of delivering a radiofrequency could have been tried. Adequate bowel preparation, which is very important before the procedure, was neither mentioned in any of the procedures, and the study involved only a small sample size. So the take-home message is pulse radiofrequency of sacral roots when combined with superior hypogastric neurolysis for pelvic and perineal cancer pain has the following advantages. It improved the VAS scores post-procedure. It reduced the morphine consumption post-procedure, and also there was a greater level of patient satisfaction. Thank you.
Thank you, Dr. Sasmit. So now we go to the second speaker, Dr. Maitri. You may start to share your screen. Dr. Sasmit, you may stop the sharing. And Dr. Maitri, please put up your CV slide so that I can just introduce you.
Is it visible?
Yes. So Dr. Maitri Shah is DA and M.B.B.S, and she's fellow in pain medicine at the Department of Pain Medicine, DYPU University School of Medicine, Navi Mumbai. So over to you, Dr. Maitri.
Thank you, sir. Good evening, everybody. Today, my topic is the role of double modality ultrasonographic and fluoroscopic guided superior hypogastric plexus neurolysis in treating intractable pelvic cancer pain. It is a comparative study taken from Journal of Pain Research from May 27, 2021. The authors are Abdel Ghaffar EM et al. Performed at Department of Anesthesia, ICU and Pain Relief Center at various centers in Egypt. Moving on, introduction. Pelvic pain is one of the poorly defined conditions that originate from complex pathophysiological pain generators in pelvic organs of gastrointestinal, urogenital, nervous system, or musculoskeletal system. Around 15 million patients suffering from pelvic pain are managed by different medical specialties over time. Neurolytic pelvic sympathectomy with chemicals such as alcohol, phenol is considered as a safe and effective modality who do not respond well to medical treatment with opioids or those who cannot tolerate opioids as adverse effects. Performed anteriorly aided by CT scan or ultrasonography or posteriorly guided by fluoroscopy or CT scan. Let's start with the anatomy of the plexus. The superior hypogastric plexus is one of the paravertebral sympathetic ganglia located in the lower border of L5 vertebrae, as shown in the figure, and the upper part of sacrum in the retroparietal space. Continuing, it's the continuity of celiac plexus, as shown in this figure, and the lumbar sympathetic ganglia related to the bifurcation of the aorta and the ureter. The superior hypogastric plexus has a sympathetic connection, both efferent and efferent fibers with splantelic nerves and the aortic plexus. It innervates the viscera of pelvis, including urinary bladder, ureter, sigmoid colon to the anal canal and upper vagina. Superior hypogastric neurolytic block is performed to block visceral pelvic pain due to pelvic malignant pain, interstitial cystitis, pelvic inflammatory disease, and endometriosis. Moving ahead, the methods. Inclusion criteria were patients above the age of 18, severe visceral pain of VAS score more than 7, pain was either refractory to medical treatment, side effects of the drugs were not tolerated by the patients. Exclusion criteria involve patient refusal, coagulation disorders, local or systemic sepsis, previous neurological or psychiatric disorders, history of addictions, distorted local anatomy, advanced respiratory or cardiovascular disease, known to have any allergy of the used medication. Methodology: 60 patients with advanced or recurrent cancer of bladder were enrolled in this study. A computerized random list was prepared and the patients were randomly allocated in two groups. Number one, group S, that is ultrasonography, included 30 patients where the superior hypogastric block was done under ultrasound guided using the anterior approach and confirmed by fluoroscopy. And group F, which included 30 patients where the superior hypogastric plexus block was done under fluoroscopic guided using the posterior oblique approach. Method: patients were instructed to fast for 8 hours. Clear of liquids were allowed before the procedure. To identify the urinary bladder at the beginning of the procedure, an interventional radiologist perform a pelvic ultrasound to scan the pelvic structures, identify the urinary bladder, and then the color Doppler on the urinary bladder will show the so-called urinary jet, which is the urine coming from the ureter to the bladder of the visco-ureteral junction. In the operating room, the patients were monitored with ASA standard monitors. An IV line was inserted, oxygen was supplied via nasal cannula, patients were sedated with fentanyl and midazolam. For all patients, bowel preparation was done with bisacodyl and activated charcoal, and all patients were instructed to empty their bladder before starting the procedure. Now, ultrasound guided technique. The technique was done under complete aseptic conditions with patients in supine position. The division of the abdominal aorta into its two common iliac arteries were identified using the curved ultrasound transducer placed longitudinally. That's here, and commonly known as the eagle sign, what we see. And then the body of the fifth lumbar vertebrae was identified by rotating the transducer transversely, as shown in the figure. Local infiltration using 1% lidocaine was injected at the entry site 1 to 1.5 inches below the umbilicus. Next, a 22 gauge 15 centimeter Chiba needle was introduced in the out of plane technique, advanced away from the vascular structure using the Doppler mode until the bony contact with L5 is achieved. The needle was then withdrawn for 2 mm to avoid injection into the periosteum. A 3 ml contrast medium was injected, followed by anterior, posterior, and a lateral fluoroscopic image to confirm the distribution of dye. The ultrasound probe was again applied, and 8 ml of 8% phenol in saline was injected, and the uniform distribution was confirmed under real-time sonography. Then a 0.2 ml lidocaine 1% was injected, and the needle was removed. This was done to avoid any fistula formation. The second technique is fluoroscopic guided oblique technique. In this, the patient was placed in prone position with a pillow under the pelvis to flatten the lumbar lordosis. After steep and cephalic orientation of the C-arm to straighten the lower border of L5 vertebrae in the PA view, the C-arm orientation of 20 to 25% obliquely, and the entry point was located at the lower border of L5 vertebrae as shown here. LA was injected 1% lidocaine at the entry side. A 15 centimeter 22 gauge Chiba needle was inserted in the direction of the irradiation beam. The Chiba needle was manipulated until a reasonable depth, that is approximately 7 to 8 centimeters. The needle was more inserted anteriorly to the psoas fascia. The procedure was repeated on the other side. Then 1 to 2 ml of contrast medium was injected after negative aspiration, outlining smoothly the L5-S1 junction, both up and down without posterior spread towards the nerve root. The posterior anterior view was taken to confirm favorable dye spread. The 4 ml of 8% phenol in saline was injected, and each needle, and 0.2 ml of lidocaine injected during the needle removal. All patients were transferred to recovery unit when their pain intensity and hemodynamic variables were assessed for 2 hours and then were discharged. Data were recorded by a junior pain resident who was blinded to the study protocol, patient enrollment, and technique. The primary end point was VAS assessment, that is the visual analog scale. 0 means no pain and 100 means the worst imaginable pain. The secondary endpoints were duration of technique, duration of X-ray exposure, satisfactory score, etc. And third, all these scores were measured at pre-procedure, 1st, 4th, 8th, and 12th week. Any side effects of the procedure were detected and recorded, such as hypotension, nerve injury, needle discomfort, etc. Coming to results and discussions, this is a flow chart showing how 86 patients were selected, out of which 69 were randomized because of the 70 could not fit the couldn't fit in the inclusion criteria. 35 were allotted to group S and 34 were allotted to group F, and that's how 30 patients were taken in each of the groups, because some patients lost follow-up, some patients refused to continue with the treatment. Following the results. First, the demographic data. Demographic data in either of the groups were almost similar. The VAS score. So the pre-procedure VAS score was similar in both the patients, both the groups, but there was significant difference at 1st week, 4th week, 8th week, and 12th week in both the groups, stating that group S had a better pain relief. Next, duration of the procedure and X-ray exposure. Obviously, the sonography group had lesser X-ray exposure, and also the duration of procedure was less. The satisfactory score. Pre-procedure, it was almost the same for both the groups, but there was significant difference at 1st, 4th, 8th, and 12th week. No, 8th week. At 12th week, there was no significant difference in the satisfactory score. Moving on, the patient global impression of change score. This score means how patient interprets the treatment for themselves. Pre-procedure, it was the same for both the groups, but over the 1st, 4th, and 8th and 12th weeks, patients were more satisfied in group S compared to group F. Quality of life, again, pre-procedure, it was the same, but it improved over weeks for group S over group F. The main important point here in cancer patient is morphine consumptions. There was statistically pre-procedure consumption of morphine was similar in both the groups, whether ultrasonography or fluoroscopy, but there was a statistical significant difference in morphine consumption at 1st, 4th, and 8th week. 12th week, there was no significant difference in the score. Next, there were the adverse effects that were noted. Hypotension in 2 patients in group S and 3 patients in group F. Positional discomfort was mainly noted in the fluoroscopic group. Needle discomfort was also noted in group F. Nerve injury was noted in 2 patients in both the groups, and mainly back pain was noted more in the fluoroscopic group patients. Discussions. Disadvantages of standard fluoroscopy technique. The standard fluoroscopy posterior view is performed in relation to the spinal column, which in many cases is the site of severe spondylodegenerative changes, especially at L5-S1 level, which all interfere with the posterior lateral trajectory of the superior hypogastric plexus block. L4 level paramedian approach is time consuming, traumatic, and troublesome, as including many possible visceral and vascular injuries. The installed neurotic agent is usually away from the proper site of the superior hypogastric plexus block, namely at the L5-S1 junction, paramedian, and in the front of the sacral promontory. Whereas the benefits of USG guided techniques or the dual modality, as we were talking about, is bedside facility, less time consumption, better tolerability in frail cancer patients with poor general conditions, less radiation exposure, alternative to difficult posterior fluoroscopic approach. The potential drawbacks of this were the potentiality of injury to structures overlying the surrounding superior hypogastric plexus, such as lumbosacral plexus, bladder, ureter, ureterus, bowel, and iliac vessels, and the risk of infection from the perforating bowel. So certain precautions were taken to avoid these drawbacks. That was pre-procedure bladder and bowel preparation, Tedenberg position, that is the head low position, smaller sized of the Jiba needle, can avoid injury to viscera, and use of color Doppler mode. The limitations accepted in the study were bowel and bladder injury and lumbosacral neurological deficits due to unpredicted and uncontrolled spread of the neurolytic drug, small sample size. The patients cannot be blinded due to the nature of the intervention, which may be a source of bias, the need of larger meta-analysis to verify results, and longer follow-up periods. The critical analysis is variability of the performer's skill and expertise isn't mentioned or discussed. No mention of pain relief post 12 weeks is not mentioned. No mention of the usage and the result of hybrid modality in the end of life care patients has been discussed. No discussion or mentioning morphine consumption post 12 weeks, which is the result, didn't show a significant change in the p-value. The take-home message is the anterior ultrasound guided superior hypogastric plexus block aided by fluoroscopy is suggested to be more superior to the standard fluoroscopic guided technique in relieving pelvic cancer pain and decreasing the morphine consumption. Thank you.
Thank you, Dr. Maitri. Now, I like to request Dr. Taruna and Dr. Krishna to just ask if there are any questions or just any comments or any suggestions, anything. Most welcome.
Yeah, I think, these are excellent articles. A lot of times what we are doing is what we are comfortable with in these procedures. My practice, we mostly go with fluoroscopy guided hypogastric blocks, and the sacral root blocks we do not do for, we haven't done it, but it is definitely, as we know that pelvic pain, it is something that is not very easy to treat because of the mechanism, not just the pain because of the tumor itself, but because of the nerve involvement and obviously the involvement of the adjacent tissue. So there is a component of neuropathic pain as well as there is a component of nociceptive pain. And definitely there is a role of sacral root blocks or pulse radiofrequency ablation. The important thing is, at what point you make a decision to do these invasive procedures, or you want to consider these patients for intrathecal pump management. So for intrathecal pump, you have to understand that most of the times we will be using morphine or, I think in India, most commonly morphine is utilized, but that will not take care of the neuropathic pain as well. So there is definitely a role for hypogastric plexus blocks and sacral root ablation in these patients. So anybody has any questions? I think Anchal had a question regarding the tip of the needle use. I think that was either an error or something because they use 10 millimeters active tip, not 100 millimeters tip. The article that Maitri presented, definitely there is a role of ultrasound guided procedure. My question was the volume of neurolytic agent used. When you see the area on ultrasound and you are targeting the area, do you normally put the like 30 ml or large volume, or would you decrease the amount used for neurolysis? That's a question for the Dr. Verma and maybe Dr. Poddar. Has your practice changed the volume that you use for neurolysis when you're actually seeing the target?
So definitely we can use a lower volume because of the more accuracy. Like when we switched from celiac plexus to splanchnic, our volumes reduced, and that was in part probably due to the space available also, but also in part because of the increased accuracy. And I'm sure here also, although I have not started doing superior hypogastric in ultrasound, but definitely this is one of the things which should be done if as and when it is required. The same thing was done when we switched from the posterior approach for celiac plexus to the anterior approach, and because now we can see the target, and it's, I think, only we use only half the dose, like only 10 ml instead of the usual larger dose. So Dr. Krishna, your comment.
Yeah, good evening. Today I'm having severe cold cough. My voice may be not clear. So
no,
nice presentation.
Please continue.
Yeah, okay, nice presentation from both of you. Good. So first, what the Sasmit has, I have two questions. First, If they have done superior hypogastric block and then they have done pulse RF, which is 10 minutes, what they have done 10 minutes for each nerve. So S2, 3, 4, both sides. So it is 1 hour. So again, a patient maybe is very uncomfortable because patient has the pelvic cancer. I don't know how they have approached. Second, if they are doing the radio frequency, why they have chosen the neurolytic block? Why not they can do the radio frequency ablation of the superior hypogastric block? It is always can be done. Conventional RF of the superior hypogastric block. It's good what they have thought of doing the S234 block, because we do neuromodulation in the pelvic pain, but we are very precise in that. For the cancer pain, I don't think we are thinking of the neuromodulation. We do intrathecal pump, but for that, and I don't find it's really good procedure to do 1 hour for doing this pulse RF S234. What they have mentioned, the result is for 3 months only. So for 3 months, I think it's too much for a patient of the cancer. So I have also not done, but this thought came to me. And for Maitri Shah, actually the ultrasound guided blocks are far superior than the fluoroscopy. It's way of the practice how we are doing. So we also do the older practice doing fluoroscope guiding. Now I am shifting to the more of the ultrasound. So we are more precise, patient has the less pain, and but result wise, I think it's depend upon the skill also, how we are doing, how much, because they have shown the 3 months results. Yeah, patient satisfaction and patient safety and and patient has the more comfort is the more in the ultrasound guided. Of course, we can use the less volume. Maybe 10 ml is enough, or maybe 12 ml is the enough. So better procedure. It's a way of the only the doing how you are practicing, and it's easy also ultrasound guided. I think superior hypogastric block. So that's it.
For superior hypogastric, when you're doing ultrasound guided, Dr. Poddar, are you going, do you know if you're going through the bowel? I think most of the time you will be. And have you seen any, infection, increased infection risk with bowel injury?
No, because first of all, I have done very less, because now we have started doing the ultrasound guided. But fluoro guided I am doing more than 15 years, so I have done more of the fluoro guided, but I never got the bowel infection like that, because the needle we are using 22 gauge, very fine, and we can see our trajectory also. When we do the ultrasound guided, we can see the needle, how the needle is going, the needle trajectory you can see. So more safe, because celiac also I have seen some means better. I feel, because patient comfort is so high, patient cannot lie prone. So that's why. So that's why I'm very strange that for the first paper, how they have done 1 hour procedure, lying the patient on the prone and doing pulse RF for 10 minutes for each needle. It's lesion. It's really, I don't know. I have the idea.
It's quite difficult. Patients don't, with pain and all, it's very difficult.
Yeah, and especially pelvic cancer pain.
Agreed, ma'am. Okay, there is one question from Dr. Ranjan Kumar. She's asking whether to use 1 or 2 needle techniques for superior hypogastric block from the anterior approach.
It could be 1 needle, because you're going directly to the midline.
So in both,
you're targeting the L5 body, so you get a decent spread.
So 2 needles are used when you are using a unilateral approach, means you are entering and you're not able to reach the center, and the drug spread is not adequate. On the other hand, here we are going to reach directly the target, and much very clear. In fact, we are scared of 1 needle, so we will not put the second needle also. So I think 2 needles is especially out of question. So, Dr. Maitri, Dr. Sasmit, you want to ask anything or add anything? Okay, I think that's it. Dr. Taruna, Dr. Krishna, any comments before?
No, I think these were interesting papers and the presenters did
Yes.
an excellent job. Thank you.
Thank you. Yeah, it's nice. Thank you.
Great. Thank you all of you. Thank you, Dr. Taruna, Dr. Krishna, for joining in and sparing your valuable time, and also for mentoring the students. And thank you, Dr. Maitri and Sasmit, for the excellent presentations. Okay, so I think this is the end of it, and also the end of the season 2. This was the last webinar which we are hosting, the last journal club for the season 2. And this season we had focused on cancer pain and chronic abdominal pain. But in I think there were lots of things which were new here. We had a new time. We had group topics for seasons. We had multiple 2 faculties, 2 papers, and we discussed the papers much in advance. So I think we'll continue many of these trends, and maybe we are looking forward to suggestions for our next season. So guys, please do write into me. You already have, those of you who are not on our mailing list, please join. The link is mumbaiPainSchool.net/news, and the WhatsApp group link is in chat, or just email me, I'll send it to you. Suggestions, comments are welcome. Just mail me at mumbaiPainSchool@gmail.com. And of course, join us for our hands-on MIPSIS workshop from 16 to 18 September. I'll be putting up the registration links. So just join in when you can. So with these words, I think we end today's session, and it was really fantastic interacting with you all. This season has been very helpful. Thank you all for joining in, and see you soon. Next week, I'm going to have a talk at 9. Probably I'll post it at 9:30 as well. I'll put up the information very soon. So take care. Bye-bye. Good night.
Bye.
Thank you.
Thank you.